Okay, this is Winnipeg. We're seeing you perfect now. Or seeing the slide perfect.
And same here in Toronto. If we're all seeing the slides, I'll take the liberty of introducing our speaker for the CPPA Gen conference. Before I do that, I would just ask, well, first, apologies for the technical issues. If you could please, with the exception of Calgary, mute yourself again so that we don't see anybody but the speaker on screen as well as his slides. So we are proud and honored to have Dr. Adam Kirtan, a pediatric neurologist who has trained throughout the country and has nothing but a meteoric academic career that is nothing but a reflection of his career focused on pediatric cerebrovascular disease. Adam has trained in Queens, Calgary, and I was lucky to work with him during his stay here at CKids. He'll be speaking with us about issues related to pediatric stroke, focusing on the blood-brain barrier. If we're all technically okay, Adam, the podium is yours. Thank you again for joining us.
Okay, great. I hope everybody can hear me. Thanks very much, Leo. I was going to say before your overzealous introduction that Leo, I think, is still probably in the top 3 nicest people I've ever worked with in my extensive career that you were just describing. I guess I'll have to say that's still true for that nice introduction. So like Leo said, I'm a neurologist and not a hematologist or a thrombosis expert, and so I'm going to offer one perspective from the neurology side about what I think are sort of the most current issues that bring our two fields together. And I think, as the centers who are listening know, this is a really great synergy that I've experienced in different ways at different places. But to try and be a pediatric stroke person, you absolutely have to rely on thrombosis experts. And I think it's a two-way street, and a very valuable one that we use a lot here. And so I hope everybody on this presentation knows about that and agrees with that, and try and bring those two fields together with some of the current issues. So I sent around these objectives. I apologize that you don't have the slides ahead of time. We were trying to send them this morning, and for some reason it didn't work. These are the sort of generic objectives. I wanted to make sure people were comfortable with what these different cerebrovascular diseases are, and then appreciate both the role of disordered thrombosis and how you investigate it, and then on the other side, recognize the thrombosis-related treatments that we consider and use. Those are the big picture objectives. And what I tried to do was break that down a little bit more and think about the current issues that are the ones that we worry about and lose sleep over. I think it's probably an overlapping list between the neurologists and the thrombosis experts. These are kind of the toughest situations and the ones that are the most sort of, I think, clinically relevant and anxiety-provoking. And so I'm going to focus on this shorter list here that you can see. I hope everybody's still seeing the slides. Thrombolysis, how we treat arterial ischemic stroke. I'll touch on sickle cell, talk about thrombophilia evaluations, and I'll finish by talking about perinatal stroke, which is my main area of interest. And I'm sure most people know these are some of the more complicated areas around this topic. And I'll try and do it with a variety of cases. I'll show you one case here that will march through several of these issues right off the top. This is a 13-year-old girl who came to our center recently, healthy, normal kid, who collapsed in school one afternoon and had a dense left-sided hemiparesis. And she was rushed to hospital, got here within an hour, and was found to have a severe neurological deficit. She couldn't move her left side. She had a gaze preference, visual field cut. Her NIH stroke scale, which is a severity measure, was about 15, which is bad. And we were obviously very worried about her. This is her CT scan, and it looks pretty much normal. There's actually a subtle loss of gray-white differentiation here in the right frontal lobe, but it's hard to see. In the stroke world, we call this a good scan. She went on to have a CT angiogram, and I apologize if this doesn't project well on the telehealth screens. We took a picture of her cerebral arteries, and she's got a major problem here with her internal carotid blown up here. Looks like there might be a tear or a dissection. And when you look at these pictures of her intracranial vessels. She's got a very ragged, narrowed internal carotid artery and middle cerebral artery. So this artery is very sick. There's presumably been a clot from this artery that's gone up into the right hemisphere to cause the presenting stroke. And so what can we do about this? Well, there was evidence of a clot sitting right there at this critical location. And so the first thing you think about is whether you can remove that clot or maybe break it up. And we were in the process of drawing up TPA for her. She didn't have any of the relative contraindications. But we're also worried this might be a dissection inside of her head, which is a relative contraindication. And so there was a lot of anxiety and a lot of questioning and re-questioning. And then luckily, in front of us, she actually spontaneously improved over a few minutes. Her NIH stroke scale dropped to about 4. And so we put the TPA away. But that wasn't the end of her problems, as you'll see. So one major thrombosis issue is that of acute intervention, and this is the issue of emergent recanalization, which is now the standard of care in adult stroke. It's revolutionized that field over the last 20 years. And IV TPA within 4.5 hours is well established to improve outcomes. Now there are a variety of mechanical therapies that can complement chemical thrombolysis. And with a generally favorable risk to benefit ratio, intracranial bleeding obviously being the major complication, but those rates are relatively low. The problem in kids is that there's really very little to go on. The evidence is essentially anecdotal. The best paper to date is by Kate LaFond, shown here at the bottom. She went back through the International Pediatric Stroke Study Group, as well as all the reported cases in the literature, looked at all the cases of kids getting TPA for emergent stroke, and described a very heterogeneous sample with all sorts of protocol violations, different outcomes, a publication bias, very hard to interpret. About the only conclusion she made, which I think we would all agree with, is that kids are being given TPA, but it's being done outside of any good safety or efficacy data. And that's pretty scary, especially if you're the neurologist or the thrombosis person thinking about doing it. So the good news on that front is that there's information on the way. The thrombolysis in pediatric stroke trial is now underway. It started a few months ago. Kate LaFond is the PI. Dr. DeVeber in Toronto is the co-PI. This is going to be about a 3 or 4 year dose escalation phase 1 safety trial of TPA. It's a multi-center international trial. Children 2 to 18 years with severe stroke through a very detailed protocol that hopes to establish the safety of intravenous thrombolysis in children, and will also acquire some pharmacokinetic data and other useful data. Its primary objective is a safety trial. So stay tuned. The first patient is anxiously awaited. It's expected to happen any day now. This is how we do thrombolysis. It's complicated. This is just one. These are 3 out of our 6-page protocol from our hospital. The TIPS trial that I just showed you, their protocol looks very similar. The reason to show this is just to say that the point that I think people already know, this is a real team effort. This involves neurology, thrombosis, but also ICU, emerge, neurosurgery, and a stepwise protocol that's been designed very carefully to make it as safe and feasible as possible. If your site is not a TIPS site, there are several Canadian sites, but what we're learning from developing that trial is that protocols like this can be developed and probably executed in safe fashion, and I think the use of such protocols and their development is steadily improving at most centers. So back to our 13-year-old girl. She went to the ICU. We did not give her TPA, instead started her on a heparin infusion. I'll come to the reasons for that. And despite the heparin infusion, she went on to evolve multiple new infarcts. This is her diffusion MRI here. She's got multiple new strokes in her right hemisphere. This is that middle cerebral artery here. I hope you can see the arrow I'm using on the right. Her artery is very sick, continuing to throw clots. And somebody's microphone's on. And so despite the heparin infusion and good values, she continued to have recurrent strokes. Aspirin was added. She had more strokes. And out of desperation, Plavix, clopidogrel was added as well. So she's now on triple antithrombotic therapy, which is a scary thing to do. And her strokes actually settled down. This is her conventional angiogram. For those of you who aren't used to looking at it, this is the internal carotid artery here. This is it blown up on the right and into the middle cerebral artery. This artery is extremely sick. We don't know whether this is an unusual dissection or a type of inflammatory vasculitis, but this artery is very sick, very likely making clots on the luminal surface that are breaking off to cause this girl's recurrent strokes. So how do we treat this? Well, we already talked about thrombolysis. And if you look next on the timeline in treating stroke, we do our conservative measures to neuroprotect, but our next options are antithrombotic therapy. The stroke's already happened, but how can we prevent the next stroke from happening? And that'll include a few options that this audience is very familiar with, although the decision-making is not always so straightforward. So there are multiple published guidelines about managing stroke in children. These are essentially consensus-based. There is modest evidence for some points made. There's the CHEST guidelines, which I'm sure everyone's familiar with, and the new version that just came out. The American Heart Association has published guidelines, and there's some UK guidelines that are a bit older. They generally agree in a lot of the basic principles of how you use antithrombotic therapy in childhood stroke, but they're not entirely consistent either. So if you look at a chart like this, which is just trying to break down basically your two options for a child with arterial ischemic stroke, are you going to anticoagulate with unfractionated heparin, low molecular weight heparin, or are you going to take an antiplatelet approach? This is the way neurologists think about it. Do I think it's a clotting system problem, or do I think this is platelet mediated? That's about the level that most of us understand this at. And then which of these two should we use? If we look at the causes of arterial ischemic stroke, there's a few where coagulation seems to be the primary mechanism. Kids with cardiogenic emboli and cardiac sources, maybe they have a known severe prothrombotic condition. And maybe, although it's less clear, things like a very critical stenosis, a slow flow state, or maybe arterial dissection, although that is quite controversial. If it's not one of those, most people and most of the guidelines would favor an antiplatelet approach, although which one you use first, because often right away you don't know what the underlying cause is really still open to discussion. Those are the acute indications. A similar approach goes forward in chronic secondary stroke prevention. Is it cardiac, prothrombotic? Do we like anticoagulation? Is it an arterial problem? Do we like antiplatelet? And the evidence supporting these is not zero, but it is pretty modest in terms of efficacy. Certainly no randomized trials to speak of to date. I don't have to tell this audience what the relative risks and benefits are of heparin versus low molecular weight heparin versus an antiplatelet like aspirin or Plavix. I think most people are familiar with those. So back to our girl. I mentioned she was on triple antithrombotics. She did well, went about 3 or 4 days with no more strokes, and then she got new headaches, and she got kind of drowsy, and then blew a pupil on the right, and we took her quickly to the scanner. She's got a large hemorrhagic transformation of one of her infarcts, a big hematoma, and she had to go to the OR and have that removed. So that's very scary. What about hemorrhagic transformation after arterial ischemic stroke? It turns out that case I just showed you is actually quite a rare entity. It's rare to have kids on 3 antithrombotic therapies. And if you look at a pair of studies published in the last year or so, this one from the Toronto group and another one from Philadelphia, the actual risk of hemorrhagic transformation, including kids who are anticoagulated, appears to actually be very low. And so these pictures are just showing, these are CT scans mostly, so what's bright is blood. This is showing examples of kids who were on anticoagulation or weren't, who had their ischemic strokes and then developed some degree of hemorrhagic transformation. And the point to get across is that these are pretty mild. These are little bits of oozing and petechiae, not big hematomas like the one I just showed you. Whether these even influence outcome is unknown, but these are certainly not life-threatening complications. This is based on a series of over 200 children with arterial ischemic stroke. And this similar study from CHOP, from Lauren Beslow and Becky Eichord, came to a very similar conclusion. That is, hemorrhagic transformation of childhood ischemic stroke is actually quite uncommon, and even when it does occur, it tends to be mild, low grade, and is certainly not a high risk when it comes to choosing anticoagulation. So back to our girl. This was her now 10 days in. You can see she's had her surgery. She's got big strokes. Her artery looks worse than ever. It's now all narrowed throughout the length of the artery, a rough surface, just presumably waiting to have further thrombosis. We put her back on aspirin cautiously after the big hemorrhage, and fortunately she actually settled down and didn't have any more strokes. In fact, this girl's done remarkably well with such large strokes. She's now back in school and has some minor neuropsych deficits, but is actually functioning very well. So what about the long term? So in this condition, kids are often left with an artery that looks much like this, scarred down, rough, turbulent flow, and we worry about recurrence. And that's based on, this is the best study to base that on from the UCSF group that looked at a population-based sample and the long-term risk of recurrence of arterial ischemic stroke. And the bottom line is that the kids with arteriopathy, I'll describe that in a minute, but sick arteries like the girl I just showed you, seem to carry all of the risk going forward. So they have a very high recurrence risk. This is over a 5-year cumulative period. And so we worry a lot about the kids who've got leftover scarred down arteries in their head. And that's where typically an antiplatelet approach is used. And the vast majority of kids will be on long-term aspirin for secondary stroke prevention. So that's one case that kind of walks through all the way from thrombolysis to acute antithrombotic therapy to long-term prevention. Just to make sure everybody's clear with the terms I'm using, when we classify stroke, it's the same as adults, different causes, but same basic idea. You block a blood vessel, that's ischemic, and I've just shown you examples of arterial ischemic stroke. You block a vein, that's venous, cerebral sinovenous thrombosis. I'll show you some examples of that. I'm not going to touch on hemorrhagic stroke today, although there are obviously some hematological conditions that put children at risk for that. I mentioned the term arteriopathy, and that's something I think that's important to take away. This is a nice study from the IPSS published last year, looking at the risk factors, what causes arterial ischemic stroke in children. And the bottom line, if you can, I hope you can make these out, but the red bar is showing that the top of the list is arteriopathy, sickness of the arteries themselves, inflammation, dissection, other rarer conditions like moyamoya disease is the single most common cause across all of childhood, regardless of age group. You'll see other common suspects on there that you would guess, cardiac disorders, other chronic conditions. But I wanted to draw your attention to prothrombotic states, which we'll talk about in a minute. They're on the list, and they're definitely relevant. I don't know if you can see these numbers, but it's something around 10 to 20% of kids who have arterial ischemic stroke, who are tested, likely have some degree of thrombophilia. But I think the point there is that's not a big number. Most kids have normal coagulation systems. And I think the general thinking is that a prothrombotic state on its own is unlikely to be the sole primary cause of an arterial stroke in children. Having said that, it's probably important to look for it and identify all possible factors in each patient. I'm not going to talk a lot about sickle cell, but it'd be hard to not mention it given the new evidence and its importance to both of our fields. So most people here know that this is the single strongest risk factor for childhood stroke. The risk is something like 400 times the general pediatric population. And we understand some of this, although I think there's still a lot that's unknown. Kids with sickle cell have problems, a different kind of arteriopathy, probably one of two main varieties, a large vessel arteriopathy that narrows down the big vessels in their brain, the internal carotids, middle cerebral, can look a lot like moyamoya disease. And those kids are at risk, of course, of squeezing off their brain perfusion or having thromboembolism from those sick arteries and big arterial strokes. What's more recently recognized is a lot of sickle kids have small vessel vasculopathy. So the little end arteries up in the brain in the white matter beside the ventricles getting knocked off gradually over time. So they don't come in with a big stroke, they come in with 2 years of falling behind in school and cumulative brain damage. Some kids are unfortunate to have both of these types of arteriopathy. Other kids with sickle disease have none, and why that is a big question. Of course, transcranial Dopplers can follow the large vessel disease quite non-invasively, easily, see when a kid is narrowing his arteries, and as people here know, I think that's an indication for transfusion therapy. And transfusion therapy has, no doubt about it, reduced the risk of stroke in kids with sickle cell. At least that's true for kids with large vessel disease, previous strokes, or elevated Doppler velocities. The relative risk reduction in the first stop trial was something over 90%, which is, in our field, that's a pretty great treatment. Of course, transfusions are more complicated than that. And I think most people know the STOP 2 trial showed that if you remove the transfusions and try to put kids off transfusions, the stroke risk seems to come back quickly. So there are many unanswered questions, one of which is, do transfusions work for the small vessel vasculopathy? That information is in process and will hopefully be available soon. And then most of you are probably aware with some of this new evidence from the past year. The switch trial took a different approach to see if maybe you can take a kid on transfusions and switch them over to hydroxyurea, something easier to take. And the switch results were disappointing, I guess, depending on how you look at it, but I think very informative. And it randomized about 130 kids to, these were kids who'd already had a stroke and were already having some degree of concern about iron overload, so they needed to, it was a good reason to try something else. And the bottom line was, if compared to kids who stayed on transfusions and chelation, the kids who were switched over seemed to, again, start to pick up that early stroke risk, and the trial was stopped early due to that risk. So I think the general conclusion from this is that there's still nothing better than transfusion therapy to prevent stroke. Well, I'm not going to talk about bone marrow transplant, but the best available treatment for stroke prevention in sickle cell. And I thought I'd mention this neat paper that came from Michael Dowling's group in Texas, who looked at what may be a different problem that we weren't recognizing before. And they had the ability to prospectively image a bunch of sickle cell kids and non-sickle cell kids while they were sick in hospital. And in particular, the sickle cell kids who were anemic and in with an illness, it was actually quite common to see them accumulate these little micro-infarcts. They were asymptomatic, but if you did diffusion imaging, you would see them during these illnesses acquire these injuries. And I don't think we know exactly why this is, but I think it's a red flag that perhaps there are elements of sickle cell cerebrovascular disease that we still don't understand and are putting kids at risk of cumulative injury over time that we need to pay attention to. Okay, I'm going to switch gears a bit. This is a different case. This is a really nice teenager. He was 14 at the time. And he came in, he has inflammatory bowel disease. He has bloody diarrhea. He was having a bad run of it for about a month. He was on steroids. He had blood loss through his diarrhea, so he was iron deficient. And he came in with some focal left-sided seizures and some headaches. And I hope you can see this, but his CT scan, top left here, shows hypodensities in both frontal lobes, big one on his right, but a small one on the left. And when we see that, we right away think about sagittal sinus thrombosis to give you acute lesions on both sides at the same time. And sure enough, that's what he had. This is a thrombosed cortical vein here. He's got thrombus in his sinus and cortical veins. And the bottom row shows his MRI, which has really helped us to understand this disease, make the diagnosis. The first two are diffusion MRI. He's got restricted diffusion. That's an infarct, a stroke. He's got a flare MRI that shows lots of edema around this. These are venous infarcts, so they're very backed up type of congested infarcts, lots of edema. And because of that, they tend to bleed into the middle. And this is a hemorrhage-sensitive image that the black is blood into the infarct. This is a very classic picture of venous infarction, and he has multiple risk factors. So CSVT has some commonality but some distinct differences from arterial ischemic stroke like we talked about. You need to know your venous anatomy, cerebral venous anatomy, to think about this condition. About half the kids who get a clot in these venous sinuses will infarct, and about half of those will bleed into the infarct because it's a back pressure type of infarction. This is data from the seminal paper that Dr. DeVeber published in the New England Journal 2001, a large series of neonates and children with CSVT. The takeaway message for today, I think, is that the causes are different, things like infection, dehydration for sure, but there's a general suspicion that blood clotting problems probably play a bigger role when it comes to the venous side of thrombosis, as I don't have to tell this group. And in her original paper, if you look down, you see that somewhere around 25 or 30% of these kids were found to have underlying blood clotting problems, either acquired or inherent. So I think it moves up the list of causative factors once we switch over to the venous side of stroke. We have great imaging now, CT venograms and MR venograms that are used and are much more sensitive now at picking up small clots and cerebral venous sinus thrombosis, and they have to be used strategically. I said in arterial that prothrombotic conditions alone probably don't account for many cases. Is that true for CSVT? I would have said no, although I've met kids like this one who had headaches and a seizure, and so he got a CT scan and they found a large clot in his jugular vein. I don't know if you can appreciate that on your monitors there. And he had prothrombotic testing because there was no other apparent risk factor. And he had terrible luck. He had lupus anticoagulant. He was homozygous for factor V Leiden, and he was also homozygous for an MTHFR mutation. So bad genetics, bad thrombosis, and So sometimes this is a big part of the answer as to why kids make clots in their head. So how important is thrombophilia in childhood stroke? I think the best state of the evidence is summarized in this paper, which I can refer you to, and I'll just try to summarize. But Jilly Kennett and Ulrika Nowak-Goddel did this really Herculean effort to pull together all the studies that have been done and very rigorously do a meta-analysis to try and look for the truth. And this is in Circulation in 2010. And it includes neonates and children with arterial and venous stroke. Teasing out those subgroups turns out to be complicated, but this is the basic message of the paper. And I'll draw your attention to a couple of points here. So these are tables from the paper. This is all children with their first arterial ischemic stroke. Down the left are a different list of prothrombotic conditions that I'm sure you would come up with a similar list if I asked you to. This column shows the number of patients. So just to make the point, this was overall pooled over 3,000 patients, case-controlled, healthy controlled. So this is rich data, I think, is the point. And when you pool them together, what you see is a variance of odds ratios of increased risk associating with this arterial ischemic stroke. And those numbers vary depending on which prothrombotic condition, but antiphospholipid antibodies, for example, very high. Odds ratio is about 7. Protein C deficiency, odds ratio is about 11. And then a bunch more in the mid-range, sort of 3 to 6, including lipoprotein a, factor V Leiden, factor II mutation. So I think the summary of this is in arterial ischemic stroke, there's no doubt that there's an association between a variety of prothrombotic conditions and your risk of having an arterial stroke. And this is basically the same table except looking at the venous side. These are the kids with first ever CSVT. And you see a similar list on the left. It changes a little bit. Antithrombin 3 kind of rises to the top. Odds ratio of over 18 is quite remarkable. And then another list of those usual suspects, protein C, factor V Leiden. And again, showing these highly statistically significant associations. So I think the take-home from this paper, it had limitations. It was very hard for this paper to tease out the perinatal population. I'll talk about that at the end. But in the childhood population, I think it helps establish what everybody's always thought. Thrombophilia can be an important underlying factor in both arterial and venous strokes in children. I think this helps to give a relative priority to that and establish at least some idea about the relative risk of what these conditions mean. What do they mean for recurrence risk, things like that? That's a less answered question, but certainly an important one. Coming back to CSVT then, this is another take-home point that I can like to make. This is, I think, one of the most important papers in our world in pediatric stroke that's been published to date, and it's undoubtedly changing management. This is from Mahendra Moharir at Sick Kids with Dr. DeVeber, and a large series of children with CSVT, so 160 plus kids. And retrospectively looking back at them, about half of them were anticoagulated. So this isn't an RCT, but I think it's the best available. And if you looked at the kids who were not anticoagulated for whatever reason, and you watched them over the first week, and almost all these kids were imaged within the first week by protocol, about a third of them would grow their thrombus. This is CSVT, so even if they had a little clot in one little sinus, about a third of them, if you looked a week later, that clot would have grown. And with that, a significant number of increased infarcts and worse outcome. Compare that to the treated group, and it was only about 5%, so quite a dramatic difference. Of course, there are potential biases about how kids ended up in these two groups, but the message, I think, is quite clear. So the point is, if you don't treat CSVT for whatever reason, and there are reasons to not do it, then you have to re-image them early. We always do it within 5 to 7 days to make sure there's no propagation. I'll show you a dramatic example. The bleeding rate in the kids who were treated was mild and small, and the outcomes were not different between the two groups. So CSVT treatment with anticoagulation appears to be very safe. This is backed up by lots of adult CSVT literature, and I think this is starting to change practice. So for the last part, I'm going to talk about stroke in the newborn and perinatal stroke, which is, I think, where we know the least about the interaction with thrombosis and thrombophilia. And this is sort of the main focus of our program here. And so I'll show you a little bit of new data and try to give you a feel for what the world of perinatal stroke is like these days. So this is why we care about perinatal stroke. It's really common compared to all the childhood stroke syndromes we've already talked about. The perinatals outnumber them at least 5 to 1 This is a much more common time period in life for stroke. We're better at diagnosing it, but we still understand almost nothing about what causes most cases. And because of that, we have no ways to treat it or prevent it. So we think it's very important. The outcomes are bad. Almost all these kids end up with hemiplegic cerebral palsy, and a lot of them have other neurological complications. This is one way to classify perinatal stroke, and I'll just walk you through it, but it's a practical way to think about a couple of different diseases, and we're getting down to more specific diseases in perinatal stroke. And you'll see why that's relevant when I show you the thrombosis data. So if you consider stroke around birth, that's what perinatal means. If you consider whether the baby's symptomatic at birth or they present later in infancy, whether it's an antenatal injury or a immediately around birth injury, and whether it's an arterial or a venous lesion, if you consider those three variables, there's three main syndromes that emerge. We also see neonatal CSVT and hemorrhagic stroke, but they're not on this list. On the left is the most common scenario that most people here have probably seen. A term newborn looks well, has a seizure on the first day of life, goes in the MRI, and there's an acute arterial infarct as shown on this diffusion MRI. We call that symptomatic neonatal arterial ischemic stroke. This is a pretty easy diagnosis to make, and it constitutes most of what's out there in the literature for that reason. It turns out, though, there's more than half of perinatal stroke are these other kids who look fine at birth, and even though they've had a big stroke at some point, they usually look normal. They go home, and then at 4 to 6 months, the parents notice that one side's not working. They bring them in. Eventually, they get an MRI. And about half of those kids will also have had an arterial stroke, but it's old. Very likely happened around the time of birth. And so we call that an arterial presumed perinatal ischemic stroke. The other half of those late presenters won't have an arterial lesion. They'll have this little venous lesion out of the periventricular white matter. We call that a periventricular venous infarct. This is secondary to a germinal matrix hemorrhage that occurred well before birth. You only have a germinal matrix up till 32, 34 weeks, and a resultant venous infarct of the white matter. There may be a thrombosis mechanism involved in that, so that's why it's relevant. This is an example of that last one, PVI. This is a fetal MRI showing this happening in real time. Here's a 26-week fetus inside its mom having a germinal matrix bleed, and they evolve a venous infarct right beside it, leaves this hole beside the ventricle. Now, this is a 2-year-old who gets an MRI, comes in with congenital hemiplegia, and we see the old injury there. And thanks to new MRIs, we can actually even see the old blood from 2 years before. So this turns out to be a common form of perinatal stroke. And in Alberta, we're building a big population-based registry of all the kids with perinatal stroke, both the arterial kind and the PVI kind. There's probably upwards of 1,000 children in our province, so more common than most people think. And as I said, we really don't know what causes most of these. The vast majority are idiopathic. Sometimes it's easy. We see major trauma around birth. We see chorioamnionitis or maybe bacterial meningitis, something that you can really hang your hat on. That's maybe 1 out of 10 cases. Most cases, we don't know what the cause is. We suspect the placenta is involved. Sometimes kids have complex congenital heart disease. But the role of blood clotting disorders has always been on the list, and the evidence behind it is variable. This is a recent study that we published last year about the big global picture of neonatal arterial ischemic stroke. This is 250 newborns with the acute version, AIS. And the take-home point for today is that when we looked at all the risk factors, and most of these kids were evaluated very formally, the yield of prothrombotic testing was actually really low. If you can, even cardiac and prothrombotic together accounted for less than 20% of these 250 cases. So it's safe to say that the most babies who are having these arterial ischemic strokes don't have evidence of a blood clotting disorder. Maybe we just don't know how to look for it, but certainly with the existing testing. I'm going to skip this one for time. So what is the role of thrombophilia in neonatal stroke? This is a nice table from Alex Maneko, who published this nice review article in Pediatric Neurology last year and tried to tease out what wasn't in the big meta-analysis I showed you a few minutes ago, what's specific about the neonatal perinatal stroke population. And what you can see on this list, I hope it projects okay, is a list of the usual suspects. If I asked you to come up with 10 thrombophilia conditions, you would start firing off these names. That's what people have done in research. It turns out, and Alex did a nice job of sort of leveling the evidence here, most of the evidence overall is modest at best, and in great need of replication with bigger numbers, case-controlled methodology. But a lot of these are appearing on the list, and it's There's no doubt there have been many children with perinatal stroke who have been found to have these, but the relative role that they play is, I think, is still uncertain. This is particularly true in the late presenters, the right side of that classification I showed you, so the presumed perinatal ischemic strokes, including the PVI. We did a small study shown here when I was in Toronto, and I just draw your attention to the bottom line. These are kids with arterial, presumed perinatal, and PVI, so none of the acute kids. And although the numbers are small, we did find a high proportion of kids had evidence, again, of one of those many lists of prothrombotic conditions. Never one or two that really jumped to the top, but this mixture of different thrombophilias in maybe as many as 50% of these cases. So that led us to do some additional testing. And I think one of the common questions that face both of us as neurologists and thrombosis people is, especially in the newborn, is, well, what testing should I do? When should I do it? And how should I do it? And there's no easy answers to any of those questions. The what, I think, is the most established. We all have that list that we've been going over and can come up with some well-established factors. When is very tricky in perinatal stroke. As I mentioned, a lot of these kids don't present until 6 months. For that reason, we've made a standard of trying to test all the kids who are diagnosed in the first year of life around their first birthday. So we have an idea of what their inherent clotting system is doing going forward in their life, which is when it matters if they're at any increased risk. Testing babies is much more complicated. The lack of normative values, the dramatic changes that occur in developmental hemostasis through the first days and weeks of life make it very hard to know what the normative values are. And there's a nice sort of commentary here about that issue. Not only when do you test, but how do you test? What lab methods do you use? What lab methods are comparable or prone to error? These are the challenges of thrombophilia testing. So with those limitations in mind, we've been doing a study here, and this is fresh off the press. I'm not even very organized, so I'm not going to go into any detail. But this is the first 85 children with perinatal stroke that we've tested, including a mix of PVI kids as well as those arterial, both acute and chronic. And don't worry about the numbers, they're too small to see. The point is that there's a mix. The blue bar is PVI, the red is arterial, the green is the whole population. And on the left is the percentage. And just in case you can't see it, I'll show my arrow here. This number here is 15%, to give you a number, where we found an abnormality based on our institutional norms anyway. And what you see are some of them are sort of standing out: antithrombin deficiency, homocysteine, which is interesting, MTHFR, which I won't get into, is a tough one to interpret, anticardiolipin antibodies, things that came out of that meta-analysis like lipoprotein A, or maybe lipoprotein A is shown here is relatively low, is about 5%. Lupus anticoagulant, 0 so far out of 85 tested. So I think the take-home message is that there's quite a lot of different and diverse thrombophilia conditions that are coming out of our testing. We're also, this is case control, and we're just starting to enroll our healthy controls. We've only got 26 so far. But in that 26, we've actually only found 5 that maybe not even significant things. And so stay tuned. There will be a one-to-one matching that comes. But we seem to be finding a high percentage across our disease population and a variety across the PVI group and the arterial groups. So I think there's definitely something there. The details will be forthcoming. So the last case I'm going to show you is a newborn, and this is another important take-home message. This is an 8-day-old baby, unremarkable perinatal history, trouble breastfeeding, maybe got a bit dehydrated. Came in at day 8, posturing and seizing. And this is the CT scan done at the beginning, and I think you can see the ventricles are full of blood. And I said I wasn't going to talk about hemorrhagic stroke, but this is an exception. If you look really closely, you'll see there's also blood here in the brain tissue. This is the thalamus. And we've learned that whenever you see this pattern in a term baby, remember, a premature baby has a germinal matrix. They have intraventricular hemorrhage all the time. Term babies don't. And so when we see this, especially with blood in the parenchyma, that is very worrisome for a deep sinovenous thrombosis. It's led to a hemorrhagic venous infarct that's then spilled out into the ventricles. And sure enough, that was the case for this baby. And thanks to nice imaging work, there's several nice studies by Linda de Vries in Holland. She's coined this term the ivy sign, and so the iris sign, sorry, like a flower. These are blood-sensitive images. You can see these little sort of flower-shaped things up into the frontal white matter. This is where the venous drainage starts. Diffusion imaging We're getting much better at recognizing this. It's tough because everything's obscured by the blood, so you sort of have to look underneath. This is an MR venogram. There's supposed to be a straight sinus right here. There isn't one. It's occluded, no flow. It backs up and causes this injury to the deep middle parts of the brain. So this baby we saw, and we said, oh, that looks like a straight sinus thrombosis, but the radiologist said, well, I don't see a clot. I don't think that it is. And for whatever reason, the baby wasn't treated. And going back to that Mohier paper, the main point, if you don't treat, you have to re-image in the first 5 to 7 days. For whatever reason, this baby wasn't re-imaged. Came back 3 weeks later with a massive head. The clot, which must have just been a little clot down here in the straight sinus, has grown, and all this gray here is blood clot filling the entire venous system. And unfortunately accumulating more injury, a big right thalamic injury. After 6 weeks of anticoagulation, the straight sinus is now there where it's supposed to be, full recanalization. But unfortunately this child has a lot of problems today because of this brain injury. So this is Yvonne Wu's original paper from UCSF that showed what I just showed you, that a high proportion of term babies with intraventricular hemorrhage actually have deep sinovenous thrombosis. You have to look for it, and if it grows, you have to think about treating it, which is a little scary when there's that much blood in the head, but the risk is probably very low. This is similar data on the same topic from the IPSS, and interestingly showed that the only single predictor of treatment versus non-treatment across the world in people treating this condition is whether you're an American or not. So the US centers are afraid of treating, and they don't, and whereas most of the rest of the world does. I think that is beginning to change thanks to the data I've shown you. And the last point about neonatal CSVT is an interesting thing that goes away from what's in the blood, but more the flow of the blood that may be important. This is a term baby with seizures at 14 hours. Diffusion MRI shows bilateral fresh infarcts. Again, makes us think about the superior sagittal sinus. Baby didn't have any clot in the sinus though, but what they did have, if you can see on the top right here, is they had marked compression of their superior sagittal sinus by this. This is their occipital bone. And some babies, when you lie them on their back, their occipital bone digs right into the superior sagittal sinus, and you can see the flow actually cuts off. And so they get venous stasis and perhaps increased risk of thrombosis, or perhaps just venous infarction. And Marilyn Tan, who we worked with in Toronto, did a really nice study looking at this as an independent risk factor, and it turns out it is. The degree of compression you have is an independent risk factor for neonatal sinovenous thrombosis. Could you fix that? Well, we thought about a simple way. Maybe we should just not lie them on the back of their heads. We tried a little simple device that you could lie the baby on to take the pressure off the venous sinus. And this is just a pilot study of 10 newborns, and found that this is flow in their different venous sinuses, and found that if you rested them that way, you could actually improve venous flow and avoid the compression. Maybe just nursing them on their sides would accomplish the same thing. So this is a new idea. We've had a few babies here recently, actually, who've had CSVT. And one of the easiest things we've done is say, just don't lie them right on their occiput because you might be blocking their venous drainage. So sometimes simple things are important. Okay, so I'm going to sum up there. There are obviously other pressing issues I didn't touch on. Congenital heart disease is a huge one. There's a very nice new paper I'd refer you to from the Sick Kids group in Annals of Neurology this year, showing the significant recurrence risk of children with congenital heart disease and stroke, and that thrombophilia may be an independent predictor of that, so very important. We really don't have good consensus yet on best primary and secondary stroke prevention strategies in children with complex congenital heart disease. This is a thrombosis issue and a big one that needs to be tackled. I'm not going to mention hemorrhagic stroke, although it is a big issue. We've had 2 children here recently with ITP. This young man passed away recently from a massive posterior fossa hemorrhage. Very sad. And then there's obviously a lot of excitement about new agents. I'm not going to tell this group about the new antithrombotic agents, but I think they are definitely applicable to children with stroke. And maybe new methods to better understand blood clotting problems in children. We obviously don't have all the answers, and I think there's a lot to be learned. So I hope we satisfied the main objectives. You feel comfortable with what these diseases are and what the relative role of thrombosis is and antithrombotic treatments. And the 3 take-home points are that thrombolysis is out there and is becoming available in children. Anticoagulation is generally very safe and needs to be strongly considered, especially in CSVT. And that the thrombophilia evidence is variable, depends on the child and the stroke syndrome, but testing is probably indicated most of the time. If you want to learn more about stroke in children, these are a couple of good family resources that you might not be aware of. they're online, the Canadian Stroke Network, and a new parent support group for pediatric stroke. And then this is our website, perinatalstroke.ca. It has links to those other websites, and it's got lots of information about perinatal stroke if you're interested. And I'm happy to take some questions. Thanks very much.
Thank you very much, Adam. To the centers that may have experienced some technical issues, I'll try to put at ease by mentioning that this talk will be available, has been recorded, and will be available on the CPTHN website. So maybe if we can entertain questions going from west to the east of the country. Are there any questions from BC Children's?
No, yeah, it's John. I'm just wondering. I'm just curious. I'm just curious about the patient that you present. The girl, the teenage girl that you present with the first patient. Does the patient have an arteriopathy?
Yeah, thanks. Yeah, she definitely does. I showed you her angiogram. So when we say arteriopathy, we mean nothing more than the term sick artery. She definitely had a sick artery. The tough part is, why is it sick? I didn't show it to you, but it could be a dissection, although it's unusual in its appearance. That we have some indirect evidence that maybe this is an inflammation, a type of vasculitis. That's a very controversial issue in our field, but it's very likely one of those two possibilities.
If there are no other questions from BC, any questions from Stollery?
No, we're okay.
Okay. Anything from Winnipeg?
Thanks, Adam. Jeff Kugler. Really quick question. You had, I think if I heard you correctly, for the later onset perinatal strokes that you see, months after they've occurred, in terms of the timing of the hypercoag workup, did I hear you correctly saying wait until 1 year was your recommendation?
Yeah, and you did hear me correct. That's what we're doing here. That was a tough decision. I don't know that anybody knows the right answer. I think the way we look at it is that when we see the acute neonatal strokes, we consider doing testing at the time. Otherwise, we test all the kids around their first birthday. The developmental hemostasis changes are, I guess, by my impression, are slowing down at that age. They're becoming perhaps a better indication of what that kid's coagulation system is like for the rest of their life, which is the main reason we want to know. Not that we can change anything that's happened. We want to know if they're at risk for something in the future. Sometimes we see kids who are 10 years old with CP who have never been diagnosed, so we test them at 10 years old. So we have a mix of data. If they're presenting in the first year of life, it's a practical way to get continuity or some homogeneity of that data across the acute presenters and the late presenters, because most of them are diagnosed by their first birthday. So that's our approach. Whether it's right or wrong, it's sort of the most practical way we've thought of to do it.
Anybody in Ottawa?
Yes, this is Jackie. I have a question. Could you comment on the length of time of treatment for the antiplatelets when you're dealing with arterial ischemic stroke, when you're talking about a 25% chance of a recurrence?
Yeah, thanks. That's a good question. Nobody knows is the evidence-based answer. I have heard some people think that 2 years is, that's a bit of an arbitrary number, but some people will treat kids for 2 years and then take them off. My approach is a bit different. I think, especially in kids like the first case that I showed, her artery still looks horrible. It did get a little bit better a few months later, but it's still ragged and narrow. There's no doubt she has, she must have turbulent flow, and her artery looks worse than most 80-year-olds with atherosclerosis, and they're all taking an aspirin a day. So my thought is, with that, what is a very significant recurrence risk, what is a very low risk of 80 milligrams once a day of aspirin, until we know better, my approach is to leave kids on. The exception I would make are, sorry, and those I mean kids with arteriopathy. The kids who have cryptogenic stroke, there's a nice new paper that just came out confirming what I think most of us have always thought, is that the kids who have no cause for their stroke, their arteries look perfect, all their workup is normal, their recurrence risk appears to be very, very low. So if they've had a cryptogenic stroke and they have normal arterial imaging, I think a shorter course of aspirin is quite reasonable. But if they have persistent arteriopathy, my approach is to leave them on indefinitely. And we also pay some extra attention to their arterial health, other things. I make them swear up and down that they're never going to smoke or do drugs, and tell them to exercise and eat vegetables and all the things we can think of to keep the artery healthy. That's my approach. The guidelines that are published don't make much of a statement beyond that.
Any other questions, Jackie?
No further questions in Ottawa.
Okay, and we have Miss Saskatoon. If not, do we have
You did
questions
miss us,
from
we
him?
don't have any questions.
Thank you.
No questions from here. Thank you.
Thank you. Any questions from Hamilton?
No questions. Thanks, Adam.
Hey, Dave.
Okay, any questions from Quebec, from Montreal Children's?
Yeah, I have two questions. So I guess one of our problems is getting the imaging fast enough. So the question would be, how do we convince our radiologists, and what should we convince them to do when the kid comes into the emergency room in the evening? And then the second question has to do with the discussion about testing for the thrombophilia, because then what do you do?
Okay, those are hard questions. So for the imaging, I think it probably is part of a bigger approach, which is why I showed the example of our protocols. I think if you want to provide, especially the acute emerging care, you need to, even if it's a one-page protocol, you need to have something on paper that all the interested parties can buy into. Radiology is the biggest one probably, but emerge, ICU, anesthesia, neurosurgery, everybody's got to say, yeah, you only get a few of those a year. If that happens, we'll do this. That approach, by the way, really helps too, that it's not a big burden. It's an every now and then occurrence. And then for imaging, it depends which literature you want to cite. I think most of us know that MRI can give you the most information. And if you're at a center that has MR running most hours of the day, which we do here, we've arranged the highest priority for an acute stroke. We just have to ask. It doesn't always happen that way, but it's supposed to. They will pull a kid out of the MRI and put our stroke kit in as part of this acute treatment protocol. I think you need to have a backup plan for if it's 3 in the morning and your MR techs are miles away. Our protocol has a CT angio backup plan that is also quite a reasonable way to assess suitability for thrombolysis. I think you need to know your center, and you need to have an open discussion with your radiologists about the importance of this. Time is brain. There are good treatments available. We need to know now, and it's pretty hard for them to argue. If you want a spine MRI, all you do is say, I think there's a compression, and they do it right away, right? It's the same for stroke. Your second question about the thrombophilia is very tough to answer. I do take exception to the idea that in terms of the insurability issue and, do you want to test for things and then you find that he's factor V Leiden, and then is that going to affect his life insurance? I'm not an actuary. I don't really understand life insurance, but I think mild thrombophilias like that are relatively, it's not that they're insignificant, but a child who's had stroke or recurrent stroke, I think would probably put off an insurance company to a greater degree if they had a stroke when they were a baby. So I personally don't think that's a strong reason to not test. And on a more sort of medical reason, I think we know there's an association. The kid is definitely at high risk of having some inborn or some thrombophilia. If it was me or my child, I would want to know going forward so that I made good decisions about, when I was having surgery, or if I was a woman who wanted to go on the birth control pill, or I was smoking cigarettes, or all those risk factors. I realize I'm trying to talk about thrombosis to thrombosis people, which is probably not a smart move, but this is the way that we would think about it. So if for those reasons, I think the benefit of testing outweighs the downside. And what I do is with the help of our thrombosis colleagues here, we provide basic counseling. When we find something, we talk about it, and usually it's some mild increased risk. So we provide education and counseling and probably reduce their risk of lifetime thrombosis, I would think, and I think that's a good thing.
Any questions from Saint-Justine?
No question, thank you.
Thanks. And I don't know if we have Halifax with us today. Any questions from IWK? Or St. John? Or London? So just a final reminder, please send your electronic evaluations to my website, which is posted on CPTGen. And given that we are trying to make this a CME accredited session, and if there are no further questions, again, I'd like to thank Adam for his willingness to contribute and to teach more about pediatric stroke, and wishing all the sites a happy holiday season, hoping to reconvene during the spring session. Thank you very much.
Thanks, Leo. Any questions from here?
How about questions here?